Good afternoon, everybody, and welcome to the Yorkshire Care Equipment webinar on understanding Huntington's disease. Hope you're all having a good day. Hope you can all hear me loud and clear. We're delighted today to be partnering with Justine Duffy, a specialist Huntington's disease advisor at the Huntington Disease Association. Justine sent her slides through a few days ago, and I've taken a look. And I can confirm that you're going to be in for an insightful, information-rich afternoon. For those of you not familiar with Yorkshire Care Equipment, or myself indeed, really just a very brief overview and a little bit of background to us. My name is Graham Wilson. I work here at Yorkshire Care Equipment. We've been providing specialist care equipment to the NHS, care organisations, and private individuals for getting on for 5 decades. Now, one of the things we kind of pride ourselves in is we kind of strive to develop and identify products that really take care equipment forward and make a real difference. Our range of specialist seating, from the bariatric chair that you can see on the left-hand side to the pediatric chair on the right-hand side, they're fully adjustable. They adjust to cover the population pretty much from 5 years old to 50 stone in terms of the bariatric chair. And they're packed with features as well. So even down to the smallest feature, removing Velcro and replacing it with magnets to assist with infection control. In terms of our hospital seating, we wanted our hospital chairs to be the best and exactly what the NHS required. So we actually worked with 2 hospital trusts to identify all the specific needs in terms of the flexibility, but also so that the chairs would stand up to the robust requirements of portering within hospitals. And Aintree Trust were a fantastic partner in that. The Razor chairs, Razor M and the Razor 2, one manual, one powered, have really taken the task of raising a faller back to a seating position, really taken that forward. They're one-person operations and so much simpler for the care involved and also for the faller. I mentioned that we like advanced, innovative products. The hip guard belt on the right-hand side is a case of taking technology from one sector and applying it to an age-old problem. It actually brings car airbag technology to, say, frequent fallers from hip fractures. Just a really cool thing. So that's just a little bit of background about who we are and what we do. One thing to mention in relation to the webinars is that given what we do, it gives us the opportunity to extend this channel to practitioners to share insights and learnings and hopefully, help our audience, as Justine's going to do this afternoon. I'm sure you'll find that hugely informative. At the end of Justine's session, we'll be having a Q&A. Justine will be staying online for that, and we'll be picking off as many of the questions as we possibly can. Just pop them into chat as we go through the webinar. So on that note, I shall pass across to Justine, and she'll take you through a significant amount of information around understanding Huntington's disease.
Thanks, Graham. Hi, everyone. My name is Justine Duffy, and I'm a specialist Huntington's disease advisor, and I work for the Huntington's Disease Association. I cover North Yorkshire, East Yorkshire, and West Yorkshire, all on my own. We're very thinly spread, so if you do get in touch with me after today, apologies if I don't get back to you straight away, because we are very busy. And I would love to know later, Graham, how you sort of advertise these webinars and recruit for them, because we certainly don't get this high of a number when we do our own at the HDA, so I'd be interested to know a bit more about Okay.
Yeah, I'll help you out on that one.
Thank you. So I will just put my screen on share if you just let me know if you can see it in a second. Is that on? Is that okay?
Yep.
Yeah, brilliant. Okie dokie. So we'll get started. So I've just popped in the right hand corner there a brief training session for professionals, and the reason I've put that is we are quite short on time today, and as we go through, I'm sure some of you have already got some prior knowledge of HD, but I was just saying to Graham that it's extremely complex. There are so many symptoms, there's so much to it that it's really hard to do it the justice that it deserves in a short space of time, but I will do my absolute best. So we're going to have a look at what HD is, look at a bit about how it affects the family, the genetics, and then look at some symptoms and some symptom management techniques. But I am sure there will be bits that we do miss today because, like I say, we're short on time and it's extremely complex. So we will get started. So we'll start by looking at what is Huntington's disease. So a really wordy sentence to start with. Usually get people to break this down for us when we're doing more of an interactive session with a smaller group. So Huntington's is a hereditary degenerative neuropsychiatric disorder. So we'll just break that down quickly. So hereditary means that it's genetic, so it's inherited from mum or dad. Degenerative means that it's progressive, so it's something that continues to get worse over time. Neuro means that it affects the brain, and psychiatric means that it affects moods and emotions. So a really complex sentence, but a lot more easier if we break it down. I am just going to hop off camera as well. I did mention that earlier to Graham and the team, just to make sure the slides run smoothly. So I've said hello and I'll be back on at the end for the Q&A, and you'll still be able to hear the voiceover. Okay, so the sort of name of the illness came from the chappie on the right of the screen there, George Huntington. So he was an American physician, and he used to go out on the back of the horse and cart with his dad and his granddad, who were also doctors. And when he was about 22, he wrote a paper which was about some of the things that he'd observed, particularly in relation to the chorea, which is the involuntary movements that we often see in Huntington's disease. So that's available to access on the internet, and that's sort of where it all began and the first proper documentation of it. You might still hear the illness referred to as Huntington's chorea, which was the original title. But as it's not just a movement disorder, it changed to Huntington's disease some years ago, just to give it the justice it deserves, really, because it encompasses so much more than just movement. But I do hear lots of GPs and things still referring to it as Huntington's chorea, so you might hear that jotted about from time to time. Symptoms of the disease normally start sort of the middle age bracket between 30 and 50. Now, this is not set in stone, but that's sort of the, you know, the norm, if you like. That's what we tend to see. But I've got quite a few patients that haven't developed symptoms till their 70s. And it is also possible to develop juvenile HD, which means before adulthood, so during childhood, before the age of 18. Again, that's also rare, and it's usually less than 10% of those with the faulty gene that have a juvenile onset. The prognosis for the condition is about 15 to 20 years from symptom onset, and that reduces down to 10 to 15 years for a juvenile onset. Again, that's not set in stone. You'll sort of see today that there aren't many black and white answers with HD, but again, that's just sort of the norm that we tend to see. Okay, so we know that Huntington's is a genetic condition, which we've just mentioned on the previous slide. And a gene is just a piece of biological information that we inherit from our parents, and genes are present in every cell of our body, and they tell them our cells what to do. So the gene that causes Huntington's disease is often called the Huntington gene, and it's attached to chromosome number 4. The gene produces an important protein called Huntington, which is needed for nerve cells in the brain and for our body's development. But when the Huntington gene is faulty, it produces a mutant Huntington protein, which produces a certain genetic sequence too many times. And this sadly damages nerve cells in the brain, but how and why is not yet fully understood. So the genetic sequence that we are talking about is the CAG sequence, which you can see on the second bullet point there. So often if somebody gets a test to find out whether they've got the Huntington's faulty gene, they will also get what we know as a CAG repeat score, and they will find out how many times their sequence has repeated. We could go into that today looking at CAG repeat scores, but it's quite complex and it's probably not too relevant today. But if anybody's interested, we can always have a separate conversation about that outside of the meeting. So we've all got the Huntington gene and we've all got Huntington protein, but we don't all have the faulty gene and we don't all have the mutant type of the protein. So each child of an affected parent has a 50% chance of inheriting the faulty Huntington gene. And I've just put mythbust there because there are quite a few myths on the internet as there are today. So the internet's brilliant for resources and information, but there are a lot of inaccurate sources on there. So there are things online that say it only runs down the male side. That's not correct. Whether mum or dad's got it, a child has 50% chance risk. It also says things like it skips generations and things like that. Again, it's not a condition that is known to skip generations. So it was just to point out a couple of those sort of common myths that we tend to find on the internet. So it's not just down the male side and it's not something that's known to skip generations. So if whether mum or dad has the faulty gene, their children would have a 50% risk of inheriting the gene themselves. Also, just to note that, for example, if mum had the faulty gene and she had 6 children, all of those 6 children have the same 50% risk. If the first 3 are diagnosed with the gene, it doesn't mean that the other 3 haven't got it. They've all got the same 50% chance risk. I'm just checking, I can see that somebody's saying that they can't hear me. Can everybody else hear me? Are you able to confirm, Graham? Yeah, okay, I'll carry on then. Sorry, I just spotted it in the chat and I was just worried that people couldn't hear me. Okay. So a predictive test is available for anybody who is at risk, but this isn't available till the age of 18 years old. So we don't test children. It's something that's available to people once they reach adulthood. It is a simple blood test, but it's not as simple as it sounds. So what happens is, if somebody was interested in getting tested, they would need to go to the GP, explain that they've got a family history of HD and ask to be referred to their local genetics centre, which for us guys would be Leeds Genetics. Then what happens is they get signed to a genetic counsellor and they usually have to have 2 or 3 sessions with a genetic counsellor before they can have the test. So during those sessions, they would be exploring things like, is it the right decision for them? Why do they want to get tested? The pros, the cons, it can affect life insurances and things like that. And just really exploring that decision. And there's usually a few weeks between those sessions as well to give people time to process and think about that information. So it's quite a lengthy process to get tested. And actually, the norm is actually that people don't tend to get tested. The percentage uptake is not actually that high. Okay. So at the moment, we don't sadly have any cures for Huntington's disease. The only thing that we've got treatment for is sort of medication-wise is mood and movement. So there is a sort of approved medication for movement. and we have our sort of generic medications for mood, antidepressants, etc., but no known cures at the moment. So it's classed as an incurable illness. However, on the positive side, there's loads going on in the research world, which we could do a whole afternoon about today, so I won't bore you with that, but a really good website is HD Buzz at the bottom of the slide there, which sort of takes out the scientific jargon and puts things into layman's terms for us, and they do a lot of sort of recaps and overviews of research studies and trials and just what's going on in the research world regarding HD. So that's a really good place to direct you to if you're interested in that sort of thing. And like I say, lots of clinical trials going on at the moment, not lots of hope in the scientific world, and I would really hope in my lifetime that we find something. It's not necessarily going to be a cure. A lot of the trials are designed to slow down the progression of the disease, which would also be brilliant. So it might be that we don't find a cure, but we find something that gives people great quality of life for, you know, an extra 20 years or something like that, slowing down the progression of those symptoms. So looking at statistics, just to give you a bit of an idea, these are sort of the last set that we did. So approximately 1 in 10,000 people carry the HD gene in the UK, which is around 8,000 people. And there are around 32,000 people at risk. So at risk just means children, grandchildren, etc., that are yet to be tested or perhaps don't want to be tested. So we don't know their gene status because they haven't got any symptoms at the moment, but they know that there's that family history there. By comparison, the MS Society predict that over 130,000 people in the UK have MS. Now, we know that MS is also classed as a rare illness. So if we compare 130,000 with 8,000, that's a huge difference. And I think it perhaps explains a little bit why with HD, you know, we don't have the best sort of awareness, funding and things like that. So it just gives you a bit of an insight into sort of, you know, the onerous in the country. Okay. So implications. So Huntington's affects the whole family. And sort of what I mean by that is that even if somebody doesn't get a negative test result themselves, where they've inherited that faulty gene, there's still lots of issues that stem from that. So we find that a lot of people that get a negative test result, a positive test result, they haven't got the gene, they still struggle with things like survivor guilt. So they haven't got the gene, but perhaps their brother or their sister does. So they feel guilty that, you know, they're having, and another member of the family, a sibling, does. They might still very much have caring responsibilities. So even if they haven't got the gene, they might be caring for mum or dad, or again for a sibling. So it really does affect across the whole family, no matter really what that test result is. Other things include things like people that choose not to get tested often live their whole life assuming that they will have HD and they have inherited that faulty gene. So they might have chosen not to have children or not to go down a certain career path, and then realise, you know, HD never comes along and actually feel like they've perhaps made the wrong decisions or wasted time or you know, something like that. So it really does have a knock-on effect. And when people come to these training sessions, they're often quite eager to learn about the symptoms and what they can do to help. But the reason that we cover this bit is because it's really important as well to sort of know, once we start looking after someone, whether it's in a therapy role or a care role, what that person might have been through to get to this point. And family members as well. So the stress of, do I get tested? Do I not get tested? You know, have I been caring for mum for 10 years first? Things like that. So it's really important to understand this bit as well. HD can, of course, affect generations, and some people have quite a strong family history and others don't, and there can be quite a few reasons for that. So still today we are getting a lot of shock diagnoses in families. And I usually sort of quiz people on this when we're doing more of a smaller interactive session. But there's a few reasons why that can happen. So I'll just explain those to you. Not everybody always manages to guess these. So the first one is misdiagnoses. So we only got the genetic test in 1993. And prior to that, there was a lot of misdiagnoses of things like Parkinson's, severe and enduring mental health. People were labelled as just a drunk and things like that. So sometimes people get a HD diagnosis eventually because of the symptoms that they're experiencing, and they don't have a family history, and it's a huge shock, but they look back and say, oh, well, I do have a family history of Parkinson's. But actually that will not have been the case, we can now decipher. The other reason that HD can appear to come out of nowhere is things like adoption, if somebody doesn't have a solid family history. Infidelity, if somebody perhaps finds out that one of the parents, the dad isn't maybe who they thought they were. And then the third bullet point on the screen there, if somebody dies prematurely of something else. So we'll pretend there's somebody called Anna. So if Anna's mum had the Huntington's gene, but she didn't have a family history, and she passed away in a car crash at 35 before her symptoms had ever onset, so she didn't have symptom onset before she passed away in the car crash, then Anna would never have known that her mum had HD because she wasn't around for her symptoms to start. So there's quite a few reasons why we get these shock diagnoses. And again, the reason we cover this is just to explain really that sometimes when we're working with people, they don't know any more than we do, or they know just as little as some people coming here today who might be learning about this for the first time. So we've got to really look after them, because just because it's a genetic condition, people don't always have that history and they don't always know. So looking at the symptoms and how we can help. So we usually split HD into a bit of a triad of symptoms. So we've got our physical symptoms, our cognitive symptoms, and our psychiatric symptoms. And under each of these sort of categories is a real long list of symptoms, which is why I said we might not get through everything today. So I'm sure anybody that's got quite a bit of experience with HD will notice something that I perhaps miss out under one of these headings today, because the lists are quite endless and it's particularly complex. So something that it is really important to note is that while there is a general pattern of progression with the disease, people do tend to differ in the severity of the symptoms, perhaps the order they experience them, things like that. So we generally say once you've worked with one person with HD, you really have just worked with one person with HD. It's not until you've worked with quite a few that you really start to see those differences. And no two people are quite the same, which is why this sometimes doesn't feel like there's many black and white answers with Huntington's. What we do tend to find is that cognitive symptoms start first, and physical symptoms come after that. The issue with that is that at the moment, sadly, symptom onset is actually diagnosed based on motor symptoms. But we do tend to find that cognitive symptoms have started before those motor symptoms, but they are easier to mask. So once people have that symptom onset diagnosis, we often find people realizing that perhaps, they've been forgetting things, making mistakes at work, losing their place in a conversation and things like that. But these are all things that are quite easy to mask and aren't as noticeable, because we all make mistakes, we all forget things, etc. So looking at some of the physical changes first, and again, there'll probably be something under this heading that we do miss out. So changes to movement. So that includes voluntary and involuntary movements. So looking at involuntary movements first, which is their career, that is something that thankfully we do have medication for. So there's only one properly approved named medication for Huntington's for that, which is tetrabenazine. But we do see other medications commonly used which are effective, such as olanzapine and sulpiride, for example. Olanzapine is actually an antipsychotic, but it works really well for involuntary movements in HD. What we tend to notice with all of these things, and I'll try and give you a brief idea, is that there is a progression. So we know it's degenerative and things sort of progress and take a path over those 15 to 20 years. So in terms of involuntary movement, the thing that we usually notice at first is maybe some facial twitching, maybe in the eyebrows, and then maybe some upper and lower limb twitching as well in the legs, the arms, the shoulders, but usually quite subtle to start off with. That usually tends to then enhance to the point where it might become quite uncomfortable, or it might start to cause issues in daily living, such as dropping things, spilling things, falling over, etc. We do use medication if it's appropriate, if it's causing someone a lot of distress or a lot of issues in their daily living. If it's not, then we would try to avoid that. Some people get on okay and don't notice their movements, so they don't feel bothered by it, although other people might be, whereas others are very aware, and we'll talk about insight later, and they can be quite keen to do something about it. In terms of voluntary movement, again, that path of progression. So we tend to notice that initially people might trip and fall a bit. You know, we might notice they're having a few stumbles. It might get to the point where that's becoming a bit more regular, so they might use a walking aid. Again, nothing's black and white with HD. Things like walking sticks aren't always brilliant because people tend to end up flinging them around and hitting people because of their movements. Rollators are quite common, and then people might eventually end up in a chair, and then in the very advanced stages, it's not uncommon for people to be cared for in bed. But, you know, I'm sure it's sort of obvious to you all today, we would get the OT involved and the physio as well. Where possible, if there's a neuro rehab team in your area, there is one in Leeds and there is one in Bradford. We would use the neuro physios and OTs because they're just a little bit more specialist and they tend to have a bit more insight into the neurological conditions. So moving on to speech. So just a reminder, this is a snapshot today because we've got lots of symptoms to get through. So people tend to lose coordination in their throat muscles, and we notice that speech starts to decline. Again, we've got that path of progression. So we might notice initially that people's speech is a bit slurred and a bit slower, might just be the odd word that we're struggling with. And as it progresses, it becomes harder to understand and a lot more unintelligible. And again, by the very advanced late stages, we might have little to no speech. So again, I'm sure very obvious to you all today, we will get the speech and language team involved. And there is so much available to us in this modern technological world, such as voice banking, different apps, different devices. But the sort of issue with HD, as we've mentioned, nothing's quite black and white. So to use a communication aid, you have to have a physical and a cognitive ability to be able to understand how to use the device, and also that motor skill to use the device. So it isn't always possible, or it can be more of the old-fashioned aids that can be more useful, you know, like cards and things that we hold up, as opposed to some sort of touchscreen device, because you really do have to have that cognitive and that physical ability to use something like that, which isn't necessarily the case with HD because we've got all these areas that are affected. So it can be really difficult and it's not always straightforward, but there is a lot that we can do. Changes to swallow. So the muscles tend to become weaker in the throat. We notice that people often have irregular spasms in the diaphragm, which can increase the risk of inhalation and lead to aspiration or aspirational pneumonia. Again, that path of progression. So we might notice at the start that somebody's choking the odd time on food or fluid. People often ignore that because we all occasionally swallow something, say it's gone down the wrong way. But once we notice that becomes a little bit more often, that's when we would really try to get the speech and language team involved and get an assessment of that swallow. The issue, again, with it not being straightforward is that if we can catch people early enough, we can teach alternative swallow methods, which can become habitual. But if we catch them too late, then the cognitive ability might not be there to learn that. So it's really important that we keep an eye on that and try and get people involved as soon as we can. And then people usually go through that path of progression in those diet stages. So they might initially be given a list of foods to avoid, like nuts or toast, and then they might go on to small and bite-sized, and then mashed with a fork, and then pureed. And then often people are offered tube feeding once the swallow becomes particularly unsafe or difficult. And that makes up a huge part of advanced care planning in Huntington's disease. But that's a whole other topic that we could have a really long conversation about as well. Weight loss, again, another big area that's quite difficult. A colleague that I work with is actually doing a PhD research project into weight loss in HD at the moment, which is really interesting. There are quite a few reasons that we're aware of, but not everybody fits into those categories. So we're wondering if there's something else or what the predominant factor is. So just to give you a bit of an idea, it's really common to see severe weight loss in HD. Some of the issues include people with involuntary movements are moving around burning calories all day, so it's hard to keep the weight on. People can be scared of eating if they are choking regularly and they're struggling with that swallow, so they can become quite anxious, which means they're eating less. If people are choking, they can get to the point where they sort of give up because it's difficult for them to swallow, so they're just not getting that nutritional intake that they need. Motor skills, so that issue, that physical aspect, if somebody's struggling to get from hand to mouth with cutlery, although, you know, we do have adapted cutlery and things, they can again really struggle, not be getting that nutritional intake because those motor skills are affected. And then mood as well. So we'll look at mood soon, but we do see a lot of anxiety, depression and low mood with this illness, not only because the brain's affected, but because there's so much loss that comes with the disease. So lots of issues there around weight loss. And we would get the dietitian involved. And it's really common for people to be on supplement drinks and high calorie fortified diets. But again, that's a whole other conversation that we could spend a whole afternoon on. And then incontinence of both the bladder and the bowel is very common in sort of the later stages as well. So just having a look at some of the changes in the brain. So I will only do this really briefly, and if anyone's interested, we can always have a separate chat about that. I'm just aware of the time. So we've got a normal brain on the left and a HD brain on the right. So these are brains after people have passed away. So just to note some of the changes, so we can see that the HD brain has enlarged ventricles, which are fluid-filled areas of the brain. We can see that the brain has shrunk, which we can explain by the death of brain cells, which is common during the disease. So if we just sort of look, I'll get my mouse at this area around here, the brain mass has drastically shrunk compared to this normal brain on the left. And then also we can see that there are large effects on the basal ganglia and the cerebral cortex, which are the sort of two main areas of the brain that are heavily affected by Huntington's disease. So a nice colourful brain here. I think I've pulled this from one of our sort of children or teenager guides, so it looks quite colourful and friendly. I won't read this word for word again because I'm aware of the time, but just to give you a bit of an idea of where some of the symptoms come from. So we've already mentioned that the basal ganglia is heavily affected by the faulty gene and the mutant protein. This part is responsible for sort of smoothing out movements, motor control, and also helping other parts of the brain to communicate and send messages to each other. The frontal lobe area of the brain is heavily affected, and this is one of the areas that we often sort of point out to carers, paid and unpaid carers. This is where our sort of personality and our emotions are housed. So it helps us to understand the consequences of our actions, sympathise, empathise, understand what's the appropriate way to behave and things like that. So it's not uncommon for us to get people ringing up and saying, you know, hubby used to be really caring and now he seems really selfish and he's been to the shop half naked and all those sorts of things. And it's just about being aware really that this area of the brain is heavily affected and it's not the person with HD's fault. They might appear selfish or struggle to empathise, and aspects of the personality may have changed, but it's something irreversible in the brain that's been damaged that sadly we can't change, but we can adapt things around them to make that easier, which we will discuss in further detail in a few minutes. The parietal lobe is also affected, which is where we interpret our senses. And we often notice in HD that people's temperature gauge goes. So we get a lot of people who burn themselves and they don't know they've done it till they've got a big blister on their arm because they didn't feel it. A lot of people don't like personal care, and we can often pinpoint that it's because they find the water temperature very uncomfortable, so it feels much hotter or colder to them than it is. And we get a lot of people dressing inappropriately as well because they feel very hot, so they don't want to wear many clothes. And then the occipital lobe is also affected, and that's where we assess distance. So we do see people struggling with spatial awareness, coupled with issues with voluntary and involuntary movements makes mobility very difficult. Again, I can send this out and sort of go into more detail if anybody's interested after the session. So people with Huntington's disease might think slower, get stuck on one idea, not be able to do more than one thing at once, struggle to make choices, and not be able to wait. So just to give a few ideas of things that can help with some of these issues. So in terms of thinking slower, it can take somebody with HD up to 3 minutes to answer. So we've got to give them lots of time, lots of extra time. So if we ask a question, it's sort of a natural human reflex to ask again or reword it if somebody doesn't answer. So if we ask, let's say Anna's got HD, if we ask Anna what she wants for a tea and she doesn't answer us in a few seconds, we would usually ask her again or reword it and assume she didn't understand us or that she didn't hear us. But by doing that, we're actually starting the whole cognitive process for Anna again and really stressing her out. So when we're talking to people with HD, it's really important that we just give them lots of extra time to answer, because 9 times out of 10, they do give us the answer. And you can normally see the wheels turning, you know, in their eyes, the cognitive wheels turning, and it's just taking them longer to get there, that's all. And closed questions can be really useful as well. So rather than saying to Anna, what do you want for your tea? We might say, Anna, do you want shepherd's pie or spaghetti bolognese for your tea? And I'm sorry if I've just made everybody really hungry because it's that afternoon slot where you've had your dinner a bit ago, but now you're not quite near tea time. It's usually snack time and coffee time for me. So yeah, that closed question where she's still got a choice. So we're still giving her a choice. We call it limiting choice to give choice. So we're still giving a choice, but we've limited it because we're more likely to get an answer then, which means we're more likely to get their true voice. If we ask lots of open questions, we can find that people with HD just say yes or no to everything because it's easier. So they'll just say what's easier because it is getting too much cognitively. So closed questions can be really useful. Sort of having a really good routine is very useful as well. So people tend to have an instant need for gratification. They want to know what's happening and they want to know when it's happening. Again, it's hard for them to sort of empathise. So if I get there late, they probably don't care that I've been in roadworks or that I've had a flat tire on the way. They probably won't empathise with that, which is fine. So I tend to use frames of time, and this is good for the routine as well. So rather than saying, I'll come and see you, Anna, at 3 o'clock, I might say, I'll come and see you between 3 and 4. So that gives me time then to get stuck in traffic or have a flat tire or whatever it is. And hopefully I'll still get there on time then between 3 and 4. Whereas if I say I'll be there at 3 and I don't get there at 3, chances are I won't get through the door. So those frames of time can help. There'll always be a time where, you know, something goes wrong and we can't get there, and that's just life, you know, but it can be really helpful to use those frames of time. Struggling to make choices. So again, sort of limiting the choice to give choice can be really useful there. We can ask more than one closed question. We don't have to ask closed questions if it doesn't feel appropriate. We only want to bring these things in when we notice that there's an issue. We don't want to start limiting down things for people before there's a need to do so. And not being able to do more than one thing at a time. So again, in that routine, trying to stick to one activity at once and just really looking at things. So whereas we can probably make our tea, be on the telephone, have the radio blaring in the background and be having half a conversation with hubby, actually people with HD can really struggle. So for example, sometimes people might struggle with eating their meal in a noisy dining room if they're in a residential home. So they might have the radio on, there might be other residents around, and they're trying to concentrate on that swallow, which is really important because we want to reduce choking. So sometimes people prefer actually to eat quietly. This often happens at home as well. Eat quietly, separate to the family, and then go into the dining room after for the social time, or go into the living room with the family after. So they're still getting the social time, but they're also having the meal and it's safe. So they're getting the best of both worlds, but just splitting it down into one thing at once can work really well. And again, we wouldn't do that until it seemed like the right time to do so. So changes to mood. So changes in the brain can mean that people's personality and mood might be affected. So we've mentioned that with that frontal lobe part of the brain. The other thing just to note as well is we often see people struggling behaviourally and with poor mood. And not only is that area of the brain affected, but there's so much loss that comes with the illness that people sort of have the right to be upset. So people tend to have to give up driving, work eventually, they lose their speech, relationships often break down, people lose their swallow, their mobility, and the list goes on. So it's just about being mindful that not only is the brain, that area of the brain affected, but also there's so much loss that comes with this illness. We'd be really upset as well, and we'd probably be in a really bad mood as well. So what makes people agitated and upset? So we do have a bit of a checklist that we often go through if we're really struggling with someone behaviourally before we start looking at medication, because it's nice to try and look at sort of the environmental things first before relying on medication. So just a few examples of some of the sorts of things that we might look at on the checklist. Is somebody hungry? Are they struggling with the swallow? Are they getting enough nutrition? They might actually be really hungry. is somebody struggling with communication? If we're asking them to repeat themselves every time they speak because the communication, the speech has been affected and it's got really slurred and it's quite unintelligible, that's stressful for them. Are we utilising communication aids and things? Is the person too hot or too cold? Has that temperature gauge gone? Does the water at shower time feel really hot to them? Is that making them uncomfortable? Does the room feel hot? Are they over-medicated? Have we sedated them to the point where they can't do anything all day, so they're not actually getting much quality of life? Are plans changing at the last minute? We know that people with HD don't like last minute changes because it's hard for them to cognitively absorb and understand that. Are we sticking to the routine? Are there any other residents that are stressing them out? Are they socially embarrassed? Are people looking at them because of their movements and their speech? We get a lot of people being accused of being drunk because their speech is slurred and then they're falling over and things. So there's lots of different things that we can look at, and that's just a few of them, just to see if we can pinpoint what might be going on and what can we change to make that person more comfortable without necessarily, or as well as, looking at medication. And stimulation as well. So just because somebody's got HD, it doesn't mean that they want to sit there all day and do nothing. They perhaps don't want to be overstimulated because that can be cognitive overload, but they still want to be doing something. So what are we doing to socialise that person? So these are some of the reasons why people might struggle to control their emotions or read our emotions. People might lose their social filter. They might become scared, anxious, depressed, frustrated, irritable, and the list goes on. So the main thing is to be mindful that it's not their fault and it's us, the people around them, that have to adapt, because we can't reverse the changes in the brain. So, whether it's us changing the temperature in the room or providing more stimulation, adapting our communication, providing a communication aid, whatever it is, it generally tends to be us that has to make those changes to help. So when planning our support, consistency and routine is key, which we've mentioned. We might need to be creative, so creative language can be useful. So helper instead of carer, holiday instead of respite, things like that. A genuine symptom of the illness is lack of insight. So we get quite a lot of people that look in the mirror and they think that they're completely still, but actually they've got quite intense involuntary movements, or their speech sounds absolutely fine to them, but to us it's completely unintelligible. So it's just about trying to pick that apart. So seeing people at home can be really useful so that we get the true story, because if we speak to them on the telephone, they'll often tell us that everything's fine, and that's where COVID was a huge issue when we couldn't get out. And then just little simple things like when people come to clinic, I tend to stagger the chairs. So I'll have the person with HD just sat slightly closer to me, the person that's brought them, carer, family member, whatever, sat next to them, but the chair just slightly further back, so that if the person with HD sat there telling me everything's great, everything's fine, no issues here, their loved one, carer, whoever, can just be sat slightly behind, sort of waving their arms or pulling a face and saying, actually, that's not true. And we can always have a separate conversation about that after them without upsetting the person with HD. Sometimes insight doesn't have to be the main goal either. So if somebody does lack insight into the condition, if they think everything's fine, they're not going to want to accept help. So we don't have to sort of convince people they've got Huntington's if they don't believe so that they do, which is common. We can just try and get them to accept help around the risks. So if they'll accept that they're not getting enough food, or that the house is a bit of a mess. As long as we can get them to accept help in terms of cleaning, cooking, whatever, it doesn't have to be because of HD. We don't necessarily have to have that as part of the conversation. Allowing extra time for assessments. So one topic at once, we've mentioned closed questions, giving time, communication aids we've mentioned, and then make listening a priority. So it's hard enough for Anna with HD to answer in the first place, perhaps, if she's, you know, quite progressed. So we don't want to keep asking her again. We need to make sure that we're really listening, not trying to write something down while she's telling us the answer, because we don't want her to have to keep repeating herself. So really try and make listening a priority to prevent that from happening and stressing people out. And then just looking at times of day as well. So is Anna more fatigued in the afternoon? Is the morning a better time to have a sort of more serious conversation about her care or whatever it is? Behaviour diaries can be really useful. So they sound really simple, and often carers tell us, you know, they don't have time to fill one in, which I totally understand. People are really overstretched, but sometimes we can pick apart what's going on. So it's really useful to do one. It might be that we notice the agitation is always around meal times, and actually they're really scared of choking. Or it might be that we notice agitation is always at bedtimes, and actually their bed's really uncomfortable and they're hitting themselves on the sides of the hospital bed, or they are scared of falling out, or whatever it is. You know, is that the right piece of equipment? It might be that we notice agitation is always when they're having a shower and they think that the water feels really, really cold or really hot because that temperature gauge has gone. So it's really useful sometimes to do a behaviour diary, because we might think that there's nothing and there's no consistency to it, but sometimes we can pick it out. Or sometimes it can be something completely bizarre, like we had one where it was a particular colour that somebody didn't like the staff wearing. So one day they'd be fine with a certain member of staff and the next day they wouldn't, and actually it was what they were wearing, strangely. So it's always worth doing one just to see. And sometimes if we have a look at it, we might find something that you don't, for example, because when we're working with someone every day, we can become a bit, you know, blind to things, can't we? We all do it. So we've already mentioned we don't have to have insight as the main goal. That's fine. Sometimes people will accept help for somebody else rather than themselves. That can be another way in if somebody's not accepting of help. So it might be that they say, oh yeah, hubby is struggling keeping on top of the cleaning, let's have a cleaner in then. And it's just that way of them getting used to somebody coming into the home and having some help, but they don't think it's for them, they think it's for hubby or whoever. So that can be another way in sometimes. These are just a couple of examples I picked out. I think I've already mentioned the left one. So that's somebody's died in a home. He was getting agitated at meal times, and it turned out it was because he found the dining room too noisy, too stressful. So now he eats in his room and then he goes back in for social time after. The other example is somebody's hubby gave up work because of his HD. So wife was working more to help with the bills, and she was asking him to do the housework while she was out at work, but that wasn't getting done. She thought he was being lazy, but another symptom which we hadn't mentioned is apathy. So sometimes people can actually become neurologically apathetic, which just means they've lost the initiative and the drive to do things. So what they do now to combat that is they do tasks together so that she can act as a bit of an external motivator. And then she sets prompts on his phone as well to remind him about some of the other tasks. And she says they feel like more of a team again now. So again, some people may have just been lazy anyway. That might have been their personality. But if they weren't and they're suddenly not doing anything, is it apathy? Is it low mood? Is it both? It's just about picking that apart. So I've just popped on here. Please remember, people might not have insight into their condition, but we can be flexible in the support that we give. So it doesn't mean we can't help them just because they don't believe they have HD. It doesn't matter. We've just got to work around that. It's a very complex illness, and like I said, there'll be symptoms that we've not even mentioned today, but there's a lot that we can do to make life easier. And good support for people with HD is dependent on us around them, anticipating problems, being flexible, being patient, and not giving up. So I've just popped on a few of the resources that we have, and there are mountains more. So we have got the European Huntington's Disease Network have got some physiotherapy guidelines. There are OT guidelines as well. There's a physical activity workbook that was created alongside some exercise clips. We've got OT guidelines. We've got these OT fact sheets that are broken down into all different areas, such as seating, self-care, posture, socialising, etc. Behaviour and communication guide. We've got these which are available on Future Medicine, but I think they're linked on our website as well, which is information to support speech and language therapists, and we've also got ones for dietitians as well. They're just shown there. Information regarding oral feeding and peg feeding and things, which again I mentioned makes up a large part of advanced care planning in terms of HD. Some people are adamant from day one that they don't want tube feeding, and some people are quite open to that. And mountains more. So I don't know if you can see this because it might be quite small, but just this little snapshot of our website up here where my mouse is. There's a professionals tab, and under there are mountains of resources. There's lots of different guides, our own guides, and then other linked from other sources that we approve, like the European HD network and things. So there's something for everything on there. It's broken down into sections for different professionals, OTs, physios, dietitian, etc. So that's a really useful place to go. Our YouTube channel is also brilliant. We do run regular webinars, but we don't get anywhere near the attendance that the Yorkshire Care Equipment guys do, so I need to get some tips from them. But we have probably done a webinar for almost every topic now since COVID hit. We started doing a lot of them. So if you go to our YouTube channel, which is just Huntington's Disease Association, there's everything from dental care to mental capacity to emotional support, social activities, behavioural issues, whatever it is. We did a whole series of RT webinars. There's all sorts of really good information on there. We run the specialist advisory service. So that's me for, I assume, most people on here's area. I cover North Yorkshire, East Yorkshire and West Yorkshire. We just do anything we can. We offer emotional support, symptom management tips. We do a lot of supporting other professionals with care planning, educating other professionals, like this session today, just working closely with anyone that's involved, social workers, OTs, helping with the housing benefits, etc. The list goes on, whatever we can really. It's just somebody there that understands HD. We have a youth service that runs from age 8 to age 25 for anybody affected by HD. It doesn't have to mean that the child's at risk. It might be that they, they live with uncle who has HD or something, but their parents been tested and they're not at risk, but it doesn't mean, it's not in the family. James, the chappie on the right, is our youth worker there. He's really brilliant. We also have a message board on our website, which is an online forum where people can ask questions, share experiences, and just generally ask for advice. There is a professional section on the message board as well for OTs. We have all the social media channels. I haven't linked them today, but our name's just Huntington's Disease Association on them. And something that's important to note finally is that we always have somebody on duty at head office. So we've all got a duty slot. So if I'm not in and you need something or you've got a question, you can ring the main number here or email the main email here. And between normal office hours, Monday to Friday, we always have a specialist HD advisor on duty. So there's always somebody available to help. But if I am around, that's my direct number and my direct email as well. And I think that's it. I feel like I've rambled a lot, but I've tried to cover as much as I can in a short space of time. Thank you.
That's fantastic, Justine. Absolutely blown away by the level of information that you've provided.
Oh, you're welcome. Sorry for babbling. Oh, and that's just...
No, don't you mention it. I think we're all actually kind of this tidal wave of absolutely fantastic insight coming our way. It's great. In terms of questions, there's a couple of housekeeping questions. Anne Burden asked, as a number did, if you could forward the contact details. Obviously, I presume they're on your website, but if you give us a list of the contact details of your colleagues from the various areas, we can circulate those. Fiona Lofthouse asked about the availability of the slides, and we'll be circulating those to everybody that's registered after the session. A question from Bronner Walsh, who is working in mental health, and has asked if there's a little more you could cover on violence and aggression, as one of her service users struggles with emotional regulation.
Yeah, I mean, it might just be a good idea if you want to get in touch. So we do attend meetings and things, ward rounds, MDTs. If there's somebody particular you've got in mind, it might be better to do it on a more individual basis and discuss that particular individual, if that's okay, and work together on that. I don't know if that's okay for you.
Yeah, that's fine. And Bronner, I'm sure you can contact Justine through the information that she's given, but if not, then by all means contact myself, graham.wilson@yorkshirecare.com, and I can put you in contact. That's not a problem at all. And probably a couple of relatively straightforward questions for you, Justine. Are sufferers likely to feel too hot rather than too cold?
I get both, to be honest. I honestly get both. So a lot of people that feel too hot and don't really want to put clothes on, but then equally other homes I go into and they've got the heating on full whack, you know, sort of these last couple of weeks where we've had quite warm temperatures. So I honestly get both.
Cool. And do you cover Scotland?
No, but there is a Scottish HD charity. We cover England and Wales.
Good stuff. And question from Lindsay Murray. Do you help people identify appropriate equipment for people suffering from Huntington's disease, such as specialist seating, hoists and slings?
Yeah, so we have two of our advisors were formerly OTs, and they are currently trying to put together sort of a new guide in terms of equipment and things to direct people to. Like I said, we would try and normally use the neuro OTs if we can, just because they've usually got a bit of experience or a bit more insight into the condition. We can sort of give ideas of things that have worked for people previously, but it just depends really. Obviously, it's sort of the RT's area of expertise, the therapists, but we can sort of give ideas of things that have worked well before, or we can put you in touch with, we have got a couple of RTs that did the webinar series for us that have got particular, really good sort of experience with HD in their RT field. So they're really good people to get in touch with. And then also the RT professionals area on the message board that I mentioned on our website, that's a good place for RTs to share experiences regarding equipment and things with HD patients.
Great stuff. Well, that's the last of the specific questions. As I said, we'll be circulating all the information, the slides, and a link to the recording of this session. As I said, it's been absolutely fantastic, Justine. Delighted you could partner with us. And if you do want to catch up about about promotion of webinars, I'd be more than happy to have that conversation with you.
Oh, brilliant. Thank you. Thanks everyone for joining.
Yeah, and there's a whole lot of thank yous on the end of the chat. So great stuff.
I'll just pop the slide back on with my details. So they are on our website, and you are also welcome to share them with families. So obviously we work with families and professionals, and people often ring up and say, can I share your details? But you're absolutely more than welcome to share my direct number and email, because they're available on the internet anyway for families. So don't worry about ever doing that.
Great stuff. Brilliant. Thank you very much, Justine. And you can have that cup of coffee and that snack you were talking about now.
Yes, thank you.
Thank you.
Thanks, everyone. Bye.
Bye-bye.